Hello everyone, my name is Nehal Singh and I will be presenting the affirmative side of our debate on the motion that specific rural and remote content is requisite in health professionals education. In this presentation, I will begin by short scenario, define the scope and parameter of this debate and the problem in hand. Then I will back my point with 4 key arguments, address limitations, and conclude this presentation. Thank you for being here. At a Wapiscott, a remote community in northern Ontario, there is no permanent physician. Care is provided mainly by nurses, and when emergency arises, patients must be flown hundreds of kilometers by air ambulance to centers in Moose Factory, Timmins, or even Sudbury. Imagine what this means for family: a child with pneumonia, an elder with chest pain, or a woman in labor. All face long delays, higher risks, and gaps in care because local professionals feel unprepared for isolated practice. This is not just inconvenience, it's about patient safety, underserved communities, and Canada's unfulfilled promise of equitable access under Canada Health Act. Without rural and remote training in education, professionals step into these realities unprepared, and communities continue to pay the price. To limit the scope of our discussion, my debate partner Stephanie and I have come up with following definitions and parameters. When we say rural, we are talking about population outside the commuting zones of centers with more than 10,000 people. When we say remote, it means communities more than 350 kilometers from a service hub, often without reliable year-round road or ferry access. By health professionals, we mean regulated providers such as physicians, nurses, pharmacists, midwives, and dentists. And finally, education here refers to graduate and undergraduate courses that are specific to rural and remote regions, whether through dedicated coursework or structured placement. These definitions frame our discussion and keep our arguments focused on what rural and remote content actually mean in health professional educational content. In 2024, about 6.3 million people, which is equal to 15% of Canadians, lived in rural communities. Yet, only 8% of physicians practice in these regions. This mismatch leaves rural residents with greater health risk. In fact, they have more than double the rate of emergency department visits for conditions that should be managed in primary care, that is 24% compared to 11% in urban areas. But evidence also shows how to address these gaps. Health professionals trained in rural focused programs, such as those from Northern Ontario School of Medicine, are significantly more likely to practice rurally. Reviews confirm that rural pathways improves both recruitment and long-term retention. Early placements also boost confidence and preparedness to work in diverse settings. Without embedding rural and remote content in education, our system continues producing health professionals unprepared for the realities of rural practices. To support the motion, now I will start making the arguments. My argument number 1 is recruitment and retention. Nearly 1 in 5 Canadians live in rural and remote regions, yet fewer than 10% of physicians serve these communities. This mismatch reflects the persistent unequal distribution of the workforce. Evidence shows that the graduates exposed to rural-focused curricula are significantly more likely to enter practice in underserved areas. This effect is called rural pipeline effect. Walkerman and colleagues confirm that rural-specific training improves recruitment and long-term retention across healthcare professions. As this map illustrates, physicians' shortages are more severe in rural and northern regions of Canada. Adding rural content helps to correct this imbalance. My second argument is that about competence and preparedness. Rural practice requires adaptability, independence, and broad scope skills. Ross and colleagues found that early exposure builds these capacities. Nurses and health professionals in rural areas often manage wider scopes of practice, sometimes functioning as advanced journalists. Evidence also shows that students consistently report stronger confidence, clinical competence, and readiness following rural placements. By embedding rural and remote content in education, learners gain early exposure to diverse, resource-limited contexts, building not just knowledge but practical capability. My third argument is that rural and remote content advances equity and cultural relevance in healthcare education. Place-based training has been shown to improve service delivery in underserved and indigenous communities, while also increasing health professional retention in those same areas. Yet we know significant barrier persist. As Okoye and colleagues points out, rural learners often face digital and structural inequities that urban health professionals do not. By integrating rural-specific content, education programs can better address these challenges and prepare the professionals for the realities of care outside larger cities. Importantly, rural education also strengthens cultural competence and accountability. Welton and colleagues emphasize that exposure to diverse rural and indigenous contexts help future health professionals and current health professionals develop the sensitivity and responsibility required to meet community needs. In this way, rural and remote training doesn't just fill the geographic gaps, it directly supports Canada's broader goal of equity and justice in healthcare. My final argument is that rural and remote content aligns health professional education with Canada's health policy. The Canada Health Act emphasizes universality and accessibility, yet these principles cannot be fully realized when rural and remote Canadians still face significant gaps in access. If you look at this graph, you can see the number of rural-focused health education programs worldwide. The United States leads by far, while Canada lags behind with only a handful of programs. This imbalance highlights a gap in our education system that directly impacts our ability to meet policy goals. Evidence shows that programs with strong rural focus improve workforce distribution and support equity outcomes. Wilson 2020 further points out that despite progress, rural access gaps remain, making it essential to align training with underserved community realities. By embedding rural and remote content into education, we ensure that graduates are not only clinically competent but also responsive to the communities they serve. In short, this training bridges gap between Canada's health policy commitments and the realities of equitable care delivery. Like any other study, this study also has some limitations. Critics may argue that adding rural content takes time from an already crowded curriculum. Others may note that not all health professionals will work in rural areas. Finally, cultural safety training is broader than geography. While these are all valid concerns, the evidence is clear. Even a limited rural experience increases the chances of rural practices. Rural training does not replace urban content, it complements it, producing health professionals prepared for diverse settings. And while cultural safety applies everywhere, rural placements provide an especially powerful context to apply these skills in remote and rural communities. In conclusion, rural and remote content in health professionals education should not be optional, should be essential. It improves recruitment and retention, builds competence and adaptability, advances equity and accountability, and aligns with Canada's health policy's priorities. Without it, our education system leaves rural and remote Canadians underserved and fails to uphold the promise of the Canada Health Act. For these reasons, I strongly affirm the motion.